Welcome to ModPath Chat, the official podcast of modern pathology, featuring interviews with authors and experts on the latest science, technology, and developments in the field of pathology. Our host, Dr. George Netto, is the editor-in-chief of Modern Pathology and professor and chair of pathology and laboratory medicine at Perelman School of Medicine at the University of Pennsylvania. Here's Dr. Netto.
Welcome to ModPath Chat. Today's guest is Dr. Sanam Loghavi. She is an associate professor of pathology at the MD Anderson Cancer Center in Houston. Sanam is a very well-known expert in hematopathology and molecular pathology. Her interest happens to be in myeloid neoplasms, which is the topic of today's conversation. But Sanam, for a very young pathologist, has published 200 papers already. Her hands are in many roles in societies, from ASH, the image bank that she's the editor-in-chief, I think, of that, and to CAP, HEM5 committee, really impacting the field, an exemplary young pathologist leader. So it's my pleasure to have you here today, Sanam.
Thank you very much for that kind introduction. And thank you so much for having me today and giving me the opportunity to discuss our paper today. Thank you.
All right. So back to the paper. The paper today is actually one of several superb, in my opinion, review articles as part of the series that was necessitated to inform our audience about all the changes that came with the WHO Blue Book, 5th edition for hematopathology. Let's call it HEM5, WHO-HEM5. So that series clearly is due to a lot of genomic alterations, led to a lot of new changes. And today, like I said, we'll focus on the myeloid. But clearly, I refer the audience and viewers, as this is going to be also on YouTube, USCAP channel, I refer you to the great series of articles, including the one from today that just came out, to really drill and understand all the changes. But today we'll try to use a more practical approach, which was what Sanam intended when she volunteered to write this article. So to help you on your day-to-day practice. So with that, Sanam, I would like us to start with the precursor. It seems like this is the first time we recognize clonal hematopoiesis as the precursor. So teach us about that.
Sure thing. So, thank you very much for the paper. I think you really summarized what we tried to do with this paper. I want to start by really thanking my co-authors who were instrumental in, making this paper what it is today. Dr. Kanagal, Dr. Patnaik, Dr. Curry, Dr. Najati, and Dr. Naresh Kakeri. So, we're from different institutions, different perspectives. We have clinicians. Dr. Patnaik was our clinical expert, and the rest of the team were pathologists. And we really tried to, think of the readers when we wrote this paper and how they could use it in clinical practice. Obviously, the WHO itself is a very comprehensive guideline, that is available to everybody. It's available in an online format right now. But I think there are, as every pathologist may know and may relate to, there are nuances in applying clinical or diagnostic criteria, pathologic diagnostic criteria in day-to-day practice. Our cases don't necessarily read the books. So we tried to make this a little bit more practical while trying to be true to the classification and, staying comprehensive, but tried to make it such that the reader could actually use this in a practical manner to help, guide their sign out and essentially day-to-day pathology practice, hematopathology practice. So to start with that, I think one thing you mentioned is definitely introducing the concept of clonal hematopoiesis as a formal entity. So, to any pathologist in the room or who may be listening or who may be viewing us, clonal hematopoiesis is not a new entity. We've been talking about clonal hematopoiesis for years now in the literature. But this is the first time that it was formally accepted or recognized as a precursor lesion to myeloid malignancies in a formal classification system. So prior to this, there was no mention of clonal hematopoiesis in the previous version of the book. So, and this is a very important concept because as the concept is growing and as we're learning more about clonal hematopoiesis, we recognize that it has major implications in, various different organs and biologies and diseases. It's not just limited to myeloid neoplasms. So it's a much broader concept. But in terms of its relationship to myeloid neoplasms, including myelodysplastic neoplasm and acute myeloid leukemia, it's now recognized as a precursor lesion. So as you know, by definition, clonal hematopoiesis is a somatic mutation or a compilation of certain somatic mutations that is it exists in healthy individuals. So the patients are asymptomatic. There is no cytopenia. By definition, the CBC is normal, but there are somatic mutations that are age-related, and we acquire these mutations as we progress through life. So if you use sensitive enough methods that can detect variant allelic frequencies of less than 1% or 10 to the minus 4, 10 to the minus 5, then you can probably, pick up clonal hematopoiesis even in children. But with the methods that we have right now, let's say at a variant allele frequency, lower limit of detection of about 2% in routine NGS that we do, the majority of people over 50, 60, 70 years old are going to have clonal hematopoiesis. And as you know, most people go through life without ever developing a myeloid neoplasm. So thankfully. It is, yes, for sure. So it is a precursor lesion. So it's there, but it's not sufficient. It's not the only thing so it's, you have, usually what happens is you have some founding mutations, and for reasons that we don't really know yet, these clones tend to expand, acquire additional clonal abnormalities, and then progress to something that we call a myeloid neoplasm, manifesting as myelodysplastic neoplasm or acute myeloid leukemia. The other concept that we introduced in this review as part of the spectrum or the family of clonal hematopoiesis, in line with the new definitions and guidelines, is clonal cytopenia of uncertain significance, which we refer to as CCUS. So clonal cytopenia of uncertain significance is a step further than CH, right? So you have the mutation, but you also now have cytopenia.
So that's the symptomatic part.
That is the symptomatic part. Not necessarily, depending on the degree of cytopenia, the patient may or may not be cytopenic.
I meant the abnormality.
But yes, so now
abnormality.
You have an abnormality. You're no longer a completely healthy individual. You have a cytopenia, and that's a manifestation of, again, this somatic mosaicism or the clonal abnormality that has been acquired. Now, I think this is a very difficult area diagnostically. It poses a lot of challenges to us, and it's not entirely without clinical implications. So, the border, the defining boundary between clonal cytopenia and full-blown MDS or myelodysplastic neoplasm is morphologic dysplasia right now. The problem is that in some cases of MDS, morphologic dysplasia can be subtle, particularly when you have low-risk clonal abnormalities, like, let's say, a DNMT3A mutation, a TET2 mutation with a normal karyotype. The patient is cytopenic. And if I call something CCUS, clonal cytopenia of uncertain significance, that patient is not eligible to receive therapy for MDS, even though they may be cytopenic, even though they may be symptomatic, right? But if I call something MDS, then that patient becomes eligible for therapy. The clinicians may or may not elect to watch the patient and observe the patient, given the baseline characteristics and the degree of cytopenias. But nevertheless, the diagnosis that we put on that pathology report actually makes a huge difference in that patient's life. So this is a very challenging area that's currently actively under investigation, is being able to use other attributes other than morphology alone to distinguish between what really is early MDS and not necessarily just CCUS with what is truly a clonal cytopenia of uncertain significance.
So we'll come back to that. So, but so far, because at least for a non-hematopathologist, you did an amazing thesis here, but I want to make sure that we capture it. So you have the CHIP, or that clonal hematopoiesis of indeterminate potential, right? Which is, to me, the first time I learned about it is when I was working on liquid biopsies, and the fact that, hey, these things can be there and it don't mean much, and started the hematopoiesis, but then even solid tumors, right? The esophagus will have a clonal. So it's a universal, but as everything, we discover it in heme first, because you guys are probably smarter than the rest of pathologists. So we have the CHIP, which sounds like below 2%, which is our limit of detection of variant allele frequency, but you don't have any, like you said, you're a healthy individual, not even cytopenia. And then you start having cytopenia, and that's a CCUS. But then, is it true? Is it correct that I'm surmising that once you start having a lot of morphologically detectable dysplasia in the line, and you put somewhere here, like in that beautiful diagram in your figure 1, which the audience need to look at, because it simplified this concept, you have more than 10% of some myelodysplastic changes, and that's when you're moving to what you call MDS. But you're saying there should be other ways, because we're not so good in evaluating dysplasia under the scope, because that's so critical now in terms of you get treatment or not.
Yes, essentially, yes. I do want to make one clarification. So the 2% variant allele frequency that I referred to, so actually the definition of CHIP requires a 2% variant allele frequency. So anything below that is not diagnostic for CHIP, but really this 2% comes from the sensitivity of our assays, right? But yes, in essence, I think, it is my belief that at least a subset of our cases that are currently being classified as CCUS are early MDS, right? But we just don't have the tools. Our eye is just not good enough, maybe, to be able to tell those subtle changes. And, I think there's a lot of inter-observer variability, and also our view may be a little bit biased. We have that, like, I'll use myself as an example. I have the privilege of working at a center where I have complete access to the patient's clinical history. I have complete access to a rapid NGS panel that comes back within 3 days. So I know oftentimes when I'm actually, like, before I sign out the report, within 3 or 4 days, I know the molecular profile of the bone marrow. And so that is going to influence my diagnosis. If I see someone has transfusion-dependent anemia and they have 3 mutations, I am going to look very, very, very hard to find dysplastic cells to be able to call that MDS. Whereas, if I see some mild dyserythropoiesis, the hemoglobin's borderline low, there are no mutations, I'm not going to call that case MDS, right? So I think the art of putting the entire picture together is also a skill. But unfortunately, I understand the limitations of making a classification system. You want to make something that everybody can apply. And, you don't want to be over-diagnosing people with MDS. But at the same time, I do think that there is a subset that is truly MDS, but hasn't yet morphologically declared itself. And
I'm sure, is there a space there for digital image analysis?
Oh, 100%.
AI? I'm sure you guys beat
We're working on it.
I'm pretty sure. So maybe that's one of the tools that would help and make it more subjective. But your point about the multidisciplinary nature of getting to that diagnosis, given the clinical implication, is very important. Very well said. And then just to leave the topics, clearly when you start having blast, that 20% and more cutoff still remains. That's when you move to AML. So other than this beautiful concept, what do you think in terms of, give us a couple, I know because of limitation of of time, pick a couple of areas where you think this really WHO-HEM5 made a significant change for those of us to take note of.
Of course. So there are two, really the major change, the theme of the new classification is adopting genetic criteria, right, to define disease. Even though heme was very genetic even before this, genetically defined classes of disease have expanded, both in myelodysplastic neoplasms, which is a new terminology for what was previously referred to as myelodysplastic syndrome, and also for acute myeloid leukemia. I think one of the most significant changes, what really impacts our daily practice, is the AML defining genetic lesions. So if you look at the WHO criteria, there is now, a broad hierarchy that divides acute myeloid leukemia into two categories. One is genetically defined, the other one is morphologically defined. And, of course, the genetically defined category supersedes the morphologically defined. And when you have those genetically defined entities, with the exception of CEBPA mutated AML and BCR-ABL1 positive AML, everything else, you can diagnose AML regardless of the blast count. So you don't really need a 20% blast count anymore like we did before. Let's say if you have an NPM1 mutation, if you have a KMT2A rearrangement, if you have a MECOM rearrangement. So that's a major change in acute myeloid leukemia. And again, I think, further evidence or further support for institutions to develop rapid NGS platforms, make this information available to the pathologists, the treating clinicians, and obviously the patients, because it has major classification and downstream treatment strategy implications. And then in myelodysplastic neoplasms, the most major change is the introduction of TP53 mutated myelodysplastic neoplasms, which is a new class of disease in the WHO classification. And this really was informed by a seminal paper that was published by Elie Papamanuel and Elsa Bernard at Memorial Sloan Kettering. And, they really introduced the concept of biallelic loss of TP53 or multi-hit TP53 aberrations. And really what this means is you essentially functionally lose both copies of TP53 in that clone. And really, they showed that these patients have really, really adverse outcomes. And so, it was decided that this really is a class-defining alteration or a class-defining profile. And so it was incorporated and introduced into the new classification system. The other ones, although they are genetically defined, but they did exist in the prior classification. So SF3B1 mutated MDS, it just had another name. We recognized it morphologically before we did genetically. If you remember in the older version of the WHO, not the revised 4th edition, but the one before that, we just used to call those cases RARS, refractory anemia with ring
That's how old I am, yes. I used to make that diagnosis.
So,
so RARS, yeah. Now it's molecular.
Yeah, but now we know that the majority of those cases are SF3B1 mutated MDS. Or, del5q, deletion 5q. This did exist in the prior classifications. And of course, we recognize them morphologically before as well with the, tiny monolobated megakaryocytes. So there are, several kind of fine-tuned defining genetic events. But really, the major novel category is the TP53 mutated MDS.
And just to make sure I understood, so the TP53 biallelic one is very aggressive, is that, and requires special?
It is very aggressive, and you require you essentially need to demonstrate biallelic loss to fit into this category. So if you have an MDS with just one TP53 mutation, it doesn't qualify.
I see. And how about the myeloproliferative neoplasm? What's do you have to pick
Myeloproliferative
one?
neoplasms, there's not a whole lot of change in the myeloproliferative neoplasm category. Systemic mastocytosis has been changed a little bit. First of all, mastocytosis was kind of taken out and it became its own entity. It's no longer under myeloproliferative neoplasms. The other area that changed a little bit are the MDS-MPNs. So myelodysplastic syndrome, myeloproliferative neoplasms, the most famous one being CMML or chronic myelomonocytic leukemia. There are subtle changes to that where the required monocytic threshold was lowered a little bit, mostly again because we have other means of demonstrating clonality. So, we used to require a monocyte count of 1,000. That's been lowered to 500 because, again, you can show that the disease is clonal as long as you still have 10% monocytes. The other major change, not necessarily major, but it's a change in terminology, is I don't know if you recall or not, we used to have this category of disease called atypical chronic myeloid leukemia, BCR-ABL1 negative. So atypical CML, which was very misleading, because you called it CML, but BCR-ABL1 negative. So that's been changed to myelodysplastic syndrome, myeloproliferative neoplasm with neutrophilia, because that's essentially the manifestation of this disease is having a combination of an MDS and an MPN where the major cytosis is neutrophilic. Let's see, other changes. Really emphasis on genetic classification of disease,
which is my probably a good way to move to our last point. And I think it's in every WHO new edition we touch upon that. What happens in something like this that now you're saying even for AML there is a mutation defining for AML is no longer how many blasts. That means you have to identify all these areas that are around the globe that are developing.
Yeah.
And they're not as fortunate as your place and my place to have these NGSs or even any kind of molecular. So how do you deal with it if I'm a pathologist sitting in one of these and I'm trying to do the best I can for my patients? How did you go around that?
Yeah, I have to say, unfortunately, the therapies that our patients get are as good as the diagnoses that we can make. The WHO does something that I really like in that, they have, and this is, I think, similar across the Blue Books, where they have the essential criteria and then they have the desired criteria. And really, this was meant to capture exactly what you are saying right now, is that, you need a minimum set of criteria to make a diagnosis. And that's usually available in the majority of, settings, be it clinical, private or academic or developing or developed. And then you have the desired. So I want to say, you can probably make 80% of these diagnoses even without sequencing. I'll give you an example. NPM1 mutated AML is the largest group of genetically defined AMLs. It's about 50% of diploid karyotype AML. So obviously the gold standard is sequencing, but we also have an immunohistochemical stain that you can use that has pretty good sensitivity and specificity. And so you can use that as a surrogate. TP53, similarly, there's an IHC that we can use. If you don't have sequencing, you can pretty much infer that there's a mutation with very good sensitivity and specificity, I would say in about 80 to 90% of the cases. So, or, SF3B1, ring sideroblast. So fortunately, we have morphologic manifestations of these genetic alterations. And for the most part, you can make an informed diagnosis using good pathology skills. But also, I would say, so it probably doesn't matter as much. I think these very refined and specific criteria matter if it informs therapeutic decision-making, right? Otherwise, I think you make a diagnosis of acute myeloid leukemia and the patient gets, the best therapy that's available to them.
That's very reassuring to hear that as the WHO is intended for the entire globe and developing countries and areas that are under-resourced, one can use essential criteria, and you're right. That's what we do in every organ for WHO intentionally. Yeah. So it's good to know that you guys didn't completely necessitate that's the only way to do it is NGS.
Yes, absolutely.
Well, Sanam, thank you. This is very instructive conversation, and again is a huge topic, and I'm glad we managed at least to touch on certain concepts, and our audience now can go to the manuscript and learn the rest, and get a practical review on how really to use the new changes.
Thank you so much for having me. It's been a pleasure, and I really hope that the readers of Modern Pathology enjoy this article, and please feel free to send us feedback. If you think we can improve it, we can do better, please feel free to share with us.
Wonderful. Thank you very much.
Any opinions expressed in this podcast are the speaker's own and do not represent the views of Modern Pathology, Elsevier, the University of Pennsylvania, or USCAP. Your ModPath Chat host and scientific director is Dr. George Netto. The producers are Dr. Catherine Ketchum and Carly Hess. Technical direction is provided by Kaminsky Productions. Music by Mitch Neubauer. Thanks to the authors, reviewers, and editors of Modern Pathology for making this podcast possible.